Good afternoon, dear colleagues. It is a great pleasure to be here today at the largest aging conference in the world. Firstly, I'd like to thank the organizers, in particular, Evelyn, Cassandra, and Alex, and the entire team for organizing and putting together a clinical longevity workshop. While it's fundamentally important that we continue advancing the aging science, it is equally as important that we also create a clinical workshop and see how can we today make the most out of the very limited aging science, and how can we live happier, healthier lives and improve and optimize our own longevity. Therefore, I'll try to keep the talk very clinical, very practical, because as we go through the conference, we're going to kind of do a deeper dive into science. And really the purpose of today is what can we do right now for ourselves as we wait for the aging science to give us better cures. So I was a bit shocked, to be honest, when Evelyn called me and she was like, your topic is going to be fasting and ketones for longevity. And at first it came to me a bit like, why me? Because everybody knows that out of all the longevity habits that we have these days, fasting is the one that I personally struggle the most with. However, we do a lot of fasting at Hook and at the Buck Institute, and at our longevity research clinic, we work with Dr. Eric Verdin, Sachin Panda, and a big international research team to create both clinical programs in terms of fasting and ketones, so there should be enough content. So since we're here, today we're going to kind of do a deeper dive into three major topics. Firstly, we're going to talk about different fasting clinical protocols, covering things like time-restricted feeding, intermittent fasting, fasting mimicking diets, and also prolonged hardcore fasts. Then we're going to talk about some of the newly on market artificial ketones, so the molecule that is produced while we fast, to see if we can really kind of have our cake and eat it. And then thirdly, we're going to talk about some of the new medicines that seem to potentially give us a lot of benefits of fasting without the need to fast. So fasting is one of the very few non-controversial topics in the field of longevity, right? Like while we argue with some supplements whether they're geroprotectors or harmful, there is really no controversy around fasting, and pretty much every scientist in the world will tell you that a little bit of fasting here and there is good for you. Therefore, I won't delve too much on the benefits. I'm just going to go through the practical frameworks. So why are people fasting? Well, kind of in our research clinic and in our research institute, people try to approach fasting to improve their longevity, their overall health, often to cure metabolic diseases, improve weight loss, overall fitness, and more recently, some people have gone for it to improve mental clarity. Three fasting plans that kind of we have, and staggered in different levels, starting from the most difficult one first, is the prolonged fasting, fasting mimicking, and time-restricted feeding. So prolonged fasting is considered to be the most difficult one. And what does prolonged fasting contain? It is essentially going off food or consuming less than 200 calories per day for about approximately 5 days. Patient supplements with vitamins and electrolytes. They take no intense activity. And they then just gradually have to restore and restart their calories to prevent something that's pretty dangerous, which is a refeeding syndrome that can cause electrolyte shifts in their body and make us end up in a hospital, which is why they go pretty much off food just with electrolyte supplementation for 5 days, and then they restart gradually with low calorie, low protein. So on day one, they avoid both fat and protein. They start with around 700 calories. Day two is a bit more gradual. They introduce some low protein, and then day three, they start with kind of easily digestible protein and gradually build up calories. So they're starting from day four, they can start eating back normally. Now, the second thing is almost a bit too good to be true, only if you haven't tried it, and this is the fasting mimicking diet. Obviously, Professor Walter Longo from UCLA was one of the pioneers of this method, and it was a big paradigm shift. So this is a diet, his patented one, Prolon, consists of about 5 days of eating low-calorie food, and it goes to kind of hijack a metabolic trick that we can trick our body to get all the benefits of fasting when we consume less than 500 to 700 calories per day. So we get the exact same benefits, but we're kind of eating at least some foods so that it's not as horrible and we're able to maintain some level of intellectual and physical activity as compared to hardcore prolonged fasting. There have been multiple studies to support this method and to show that it's beneficial on many, many markers. And this diet consists of about 500 to 750 calories per day, usually about 5 days, and it's very high in good fats, low in carbohydrates, and low in protein, because we know that there is this interaction between glucose and protein. So this is basically like try to trick your body that you think you're fasting, but you're not really fasting. And this is the breakthrough, like the Prolon product, which contains kind of packed bars and soups that are calculated to have these macronutrients, but some people just end up making their own fasting mimicking diet and perhaps start a day with a cup of berries and then maybe have just a spinach salad, no sauce, and then maybe a handful of blueberries, and that covers them for about 500 calories per day. So it really depends on kind of what works for you. The third and probably the easiest method, and where we kind of say it's a good starting point to get into fasting, is this thing called time-restricted feeding or intermittent fasting, and it became very popular. Like, it's popular in social media, it's very mainstream these days. And it really involves reducing our feeding window from what used to be normal, so 14 to 15 hours in the so-called cafeteria diet of constant snacking, because we have food all around us here in the Western world. Is to say, okay, I'm going to narrow down this feeding window, and then that feeding window can be reduced to 10, 9, or 8 hours most commonly. Now, what do we look at? What are the things that we measure once we put patients on these protocols? What do we want to see if they're effective against? And it really, we look at this thing called HOMA-IR, which is a score and a measurement of your metabolic health. It looks at fasting insulin and glucose, and it's a risk predictor for type 2 diabetes. So we know that kind of this reduction in insulin increases lifespan by 25% in mice, so we believe it's a good measure. We also measure ketones. Often ketones are referred to as the efficacy measure of a different fast, and also measure metabolic flexibility. Sometimes people would compare how long the time it takes you to reach to a certain level of ketones in your blood, and that can be taken as a measure of metabolic flexibility because it shows how flexible is your body from changing from one substrate, glucose, to burning fats. And that can be trained, just like everything else in our body. So we measure ketones, and obviously we can do it either by pinprick or with urine strips, and a bit of less invasive, more user-friendly, because we tend to urinate more often than we like to prick. And it's really about the commonest ketone that we really measure here is this ketone beta-hydroxybutyrate, or short BHB. We don't really know yet the values of what level of ketosis are beneficial to trigger which process, but depending on what literature you look at, people would say that light ketosis is somewhere from 0.2 to 0.5 millimoles. The nutritional ketosis already starts at 0.5. Some people go a bit higher to 0.7 millimoles per liter, up to 3, and that is kind of the sweet spot for longevity. The very deep ketosis happens usually above 3 millimoles per liter, and that is not the level that we're targeting, right? Like, we want to be at this from kind of 0.5 to 3 millimoles of ketosis. And then obviously we look at things like LDL, which we know from Mendelian randomization studies, from multiple studies on statins, from the Framingham heart study, that actually LDL is, again, a thing that also increases with age and is associated with heart disease, and we are often aiming at a certain level. And last but not least is IGF-1, again, associated by multiple signaling, kind of a very promiscuous molecule, affected both by growth hormone and insulin signaling, seems to have multiple effects in different tissues. High IGF-1, we know, is bad and increases risk of colon cancer. Free IGF-1 is reduced by caloric restriction and fasting, and there are multiple studies that can be beneficial. But to make things a bit more complicated, IGF-1 is very tissue selective, so it's actually good to have it's harmful to have too low IGF-1 in the brain and also in the heart for plaque stabilization. So we're still learning, but too high IGF-1, not good, and also extremely low IGF-1, not great for certain tissues like the heart and the brain. And then lastly, because we're obviously here and obsessed about longevity, we also look at these measurements of biological age that are yet in development. Some have been clinically validated in data sets to have some prognostic variability. We work with multiple blood age clocks from PhenoAge to the very popular Deep Longevity as blood age, which contains about 42 blood markers that are put into a formula and then based on that predict the blood age of a patient. And we also look things like epigenetic clocks, something like the Horvath clock. However, one point that is very controversial that I like to bring up here is for patients who undergo fasting, not to be disappointed if their Horvath clock or their other measurement of epigenetic age comes up to be even higher than their chronological age. There is some speculative new research that shows that actually epigenetic clocks might measure our response to aging and stress, right? Like they see how our methylome is responding to a stressor. So if you apply a stressor like fasting, like intense resistance training, you might end up being higher because you have a higher stress response rather than compared to a population on which clocks were developed, and that is unfortunately a sedentary population eating cookies. So it's not sure when the timing of these epigenetics in terms of fasting, and I wouldn't be too sad if your Horvath clock after a 5-day fast shows as you're 62 even though you're 54. So going back to, why would you even fast? Like what improvements are really seen with these fasting methods, right? Like it's not the most user-friendly. I mean, that pistachio ice cream from the beginning was probably a bit nicer than all these fasts. Let's break it down into categories. So with the prolonged plan, right, like no food, hardcore, very difficult, requires quite a lot of psychological preparation, we can see a reduction in LDL that begins to be evident after 10 days post-fast. We can see a reduction in total cholesterol, which is mediated by a reduction in LDL and VLDL, and it starts to reduce at 10 days and it plateaus at 15. So that's where we get the optimal benefit. We have a reduction in fasting blood glucose within 5 days, which is really important if the patient is at high risk of prediabetes. And then we believe that it upregulates certain autophagy genes. So this is a process where we remove the dead and inflamed in our body, and it's really important for metabolic but also anti-cancer properties. Now, that fasting mimicking diet, where we're kind of tricking our body to think that we're fasting, well, from the studies, and this has actually been studied pretty well because we have commercial products on the market, we've seen that there are actually no significant changes when it comes to fasting glucose. So it may not be optimal for prediabetes patients, but we have a reduction in IGF-1. There's no change when it comes to LDL and cholesterol, but there is a reduction in systolic blood pressure, and this is really important considering that most people suffer from hypertension. And then we do have a significant weight loss, both fat and total weight loss. So if we're less worried about blood sugar and cholesterol and we want to drop the blood pressure, overall inflammation, and cause weight loss, fasting mimicking diet are really a great way to do so. And then what are we seeing with time-restricted feeding, right? Like just narrowing our feeding window during the day to about 8 to 9 hours. Well, this is not going to change probably our cholesterol profile, but it does improve sugar control. So it reduces insulin resistance, it reduces fasting blood glucose, and then it changes morning ketones, so after a fast. So like they found out that if you start eating at 12 rather than at 8 or 9 a.m. in the morning, your morning beta-hydroxybutyrate, the main ketone, is higher, but your evening ketones remain unchanged. And then there could be a reduction in blood pressure as well. And just recently, so these two papers came out this week, and again from our scientific advisor, who's a good collaborator, Prof. Sachin Panda and his team at the Salk Institute, that often women tend to be less responsive to some of these fasting programs. So this was a study that was a bit of an outlier compared to most studies which tend to often include more men than women in medical research. This was a study which was predominantly women, and it has shown that women, by following a time-restricted feeding window, can significantly drop weight without necessarily changes in the nutrition programs. And even more interesting is that reducing your feeding window can stop the accumulation of fat in your liver. So it can be a preventative or potentially a curative intervention for fatty liver disease, or often known as NASH, non-alcoholic steatohepatitis. This is now turned to become the commonest cause of liver disease in the Western world, even above alcohol. We have a lot of people suffering from it, and in particular, even people sometimes with normal BMIs can have it. So this seems to be, and we don't have particularly drugs for NASH. So this seems to be really interesting, really important. Obviously, we'll get a lot of further research. There are many big companies looking for drug cures for NASH, from Gordian to Google's Calico. I think this is potentially one of the best things we can do to protect our liver right now. Moving on, if fasting is going to cause us to produce ketones, can we just not take ketones, right? Like, we're in medicine, we have synthesized chemically a lot of things that our body needs. So why do we have to go through the process that raises one molecule? Can we just not take that molecule and just get the benefits? Well, people have thought of it. So we've got the ketone shots, and we have kind of two effective products on the market that are classified as safe supplements, and are sold without prescription. So the first one that has been for longer is the HMNV. So it's 25 grams, serving beta-hydroxybutyrate, so the main ketone. And the way that it's structured, it has got two ketone molecules, so two BHB molecules given as a prodrug, which is why it raises ketones quite rapidly. So we have like a very acute peak, but then they kind of drop. So it elevates blood ketones within 30 minutes, and then they drop for a short duration of effect. The second one is a bit newer. It came to the market actually this year, co-developed by Juvenescence and Dr. Eric Verdin of the Buck Institute. And it again contains 25 grams of ketones, but this one contains, again, the same BHB molecule, but it's linked to a fatty acid ester, so that it has a shorter duration, so it has like a longer duration of effect, so it reaches a smaller peak, but it lasts and stays and raises our blood ketones above the 0.5 millimoles for longer. So it was kind of based on the benefit that actually prolonged exposure to these ketones gives higher benefit, and it's potentially one of the best ketone shots on the market in terms of price. However, when the ketone shot came out, this is actually my face that I've sent to the chief scientist, Eric, when the ketone shot came up. And I was not, I was actually, my case was very common. Most people, when they've tried it, they were a bit shocked by the bitter taste. Obviously, ketones do have a bitter taste, and they try to mask it with chocolate, but it is a little bit of tough love. So the company has since changed advertising. So now they send emails saying that chocolate ketone shot is an acquired taste, but it's worth it. It's all about tough love. It's all about stressors. So they've changed the messaging from this tastes amazing to learn how to love the taste. And it really just depends, what type of love you're going for, and how you approach things. But there should be some, there could be some benefit, but you need to know how to deal with it. Lastly, we're going to talk about some of the new medicines on the block that potentially came out again in recent years that give many of the benefits of fasting metabolic disease, right? And these class of drugs are called GLP-1, so glucagon-like peptide mimetics. And they've recently been used, they've started as diabetes drugs, so to lower blood sugar. And they've recently started being rebranded as drugs for weight loss and drugs for fatty liver. So what do? They reduce glucose by multiple mechanisms, and they also kind of reduce our appetite by affecting the way the stomach empties out. So we tend to eat less and feel early satiety, right? It sounds like a wonder drug, right? And how were they discovered? Interestingly, they came out, so the first of this GLP-1 mimetics, exenatide, came out of a lizard saliva. And this type of lizard only eats once or twice a year, right? Like that is fasting nailed. So it needs to have this salivary hormone, exendin-4, to assimilate its meal because it only eats so rarely. And then we've had new drugs coming up onto the market like liraglutide and most importantly semaglutide, which can now be an injection or even an oral tablet and give many of these benefits to a selected group of patients. So these are some of the trials that have been shown for semaglutide, right? Like published in the New England Journal of Medicine to show that semaglutide can help with weight loss in certain groups who respond to it, that it can help with reduction and improvement of fatty liver and blood pressure. And weight loss can even be up to 10 to 15% of body weight. So it's now approved by the FDA for obesity. And it doesn't affect cholesterol and ketones, but it can cause weight loss in specific population. It reduces blood sugar, and then it has some preliminary efficacy for fatty liver disease. So I guess in conclusion, now that we've had like a ride through fasting and different interventions, what I would probably advise is that it's very non-controversial, and probably from today you should adopt one method of fasting. Perhaps start with time-restricted feeding, and then maybe see if you can play around with half a day or maybe once a week of a full fast or a fasting mimicking diet. Perhaps try a ketone shot, whichever one is on the market, just to see how the taste is. And then there are new medications coming up, new supplements, new interventions, and we'll stay on top of the latest science, but definitely do not rely on medications without lifestyle optimization. All pharmacological interventions should really be adjuncts, but it's really also important to coordinate our lifestyle because nothing will cover for horrible lifestyle choices, and although difficult, it's something we need to work on together. In conclusion, I'd like to thank my research team for helping create both the content, the presentation, and all the clinical programs. It's really a pleasure to have such a great international team, and obviously our scientific advisory board with Sachin and Eric. And obviously, in the meantime, I will continue having my ketone coffee to keep me alert so we can deliver more of these talks. Thank you.